Good afternoon, everyone. Welcome to the post-lunch session. So this is going to be a video-assisted skill transfer video, um, basically focusing on the steps of therapeutic keratoplasty and aimed at the fellows and budding surgeons. So, arguably, the most important surgical intervention while treating infectious keratitis is therapeutic keratoplasty. And how well you execute a therapeutic keratoplasty can dictate the prognosis for the patient's vision in the future, how good the eye is going to be to receive an optical graft in the future. But often, because of the size of the infection, you end up having to take larger grafts. Depending on the involvement of the sclera and anterior chamber, the inflammation may be very severe. You often encounter profuse bleeding, melting sclera, perforated cornea, and collapsed globes. And the grafts are usually of poorer quality. You can't really visualize the anterior chamber, and all of this will multiply your problems. And almost always, you're dealing with an inflamed eye and a very uncooperative patient, and this increases the chance of having an expulsive hemorrhage. So, I'm going to just present a few tips and tricks, if you may, while doing a keratoplasty, therapeutic keratoplasty. So let's dive into it. Over here, you can see a flat anterior chamber, and you can very well delineate the ulcer here. It's a perforated corneal ulcer with some glue placed on top of it. So whenever there's a clear corneal rim, we would prefer to make a side port to inject viscoelastics and such instead of using the graft host junction to do so. And while making the side port in a flat anterior chamber, usually the teaching is to go parallel to the iris in a formed anterior chamber, but in a flat or a very shallow anterior chamber, it would be advisable to go obliquely and then extend the side port sideways, as you can see now in the video. Extend it sideways, and then the next step would be, if possible, to fill the anterior chamber with viscoelastic. Otherwise, clearly demarcate the lesion, mark around the infiltrate without leaving any infective foci outside of the margins. Once you're done with that, next would be to trephine the cornea. So you can see the top superior 3 points that you made. The marked blade of your trephine should overlie on those 3 points, and then the rest of it will align by itself. And then you should proceed to trephine the cornea around 50 to 70%. Make sure you do not enter through and through. Yes. Next would be the donor preparation. First, we'll determine the size of the donor tissue. If you had noticed, the ulcer we had measured was around 8 millimeters. So we'll go with an 8.5 millimeter donor graft. The first thing you do is you dry the epithelium during trephination. So here we are using a 4-punch, but usually there is a Teflon block on which you lay the corneal button. The first thing you do is that you dry the epithelium so that it doesn't slip during the process of trephination. And center the button on the Teflon block or the 4-punch that's used here and apply a vertical force. What it does is, one, it prevents slipping of the graft, and you also get straight margins rather than having an oblique margin, which is going to make apposition very difficult. It's very easy to do with a 4-punch, but you might face challenges when you're using a Teflon block. So it's necessary to secure the Teflon block, ask your assistant to help you out as well. Coat the endothelium with some viscoelastic. And only then do we come to the most crucial part of the therapeutic keratoplasty, that is the host bed management. So beyond this point, it has to be touch and go, because you're going to go into an open sky sort of situation. So first we start by entering the anterior chamber, giving vertical strokes with the side port until you see an egress of viscoelastic, which would indicate you've entered the anterior chamber. Then you can grab your scissors and then enter horizontally, but then make sure you turn vertical and remain parallel to the corneal rim and start cutting around the edges. This will ensure that there are no ledges along the corneal rim. This is very important because if you try to suture the donor button with a ledge, you're going to end up with an edge lifting of the edge of the graft post-operatively. and that can lead to non-healing epithelial defects and even stromal melt in some cases. So if you do end up with a ledge or a shelf, make sure it's trimmed off properly before you proceed to the next step. So as you go about, you will have to change the direction of the blade of your scissors. There are also scissors available to be used with both your right as well as your left hand, which you can make use of. Once you get rid of the ledge, we'll now address the infective or necrotic material over the iris, anterior chamber, sometimes the angles. You need to make sure you thoroughly remove it so that there is no risk of, or you at least minimize the risk of reinfection. You can either peel it off or hold it and cut it. Sometimes you may have to um, sacrifice a bit of iris tissue that is necrosed. Next, you open up the angles of the anterior chamber by injecting visco. Mind you, all of this viscoelastic needs to be washed out at the end of the surgery, but for the time being, it is opened up nicely to prevent pus formation. And then, of course, a peripheral iridectomy away from the side of the side port, and make sure it is patent to prevent any pupillary block. Next, after dousing the surface generously with viscoelastic, you'll place the corneal button endothelium down on the surface and begin suturing. We'll start with the cardinal sutures. The first two sutures, the first one is an anchoring suture. You take a 90% bite on either side of the cornea. If your view is not clear, always clear it up so that you manage to take a proper depth. And then the cardinal sutures are usually on the tighter side because the anterior chamber is not formed yet. You cannot judge the tightness appropriately. So these sutures are going to be on the tighter side. You've locked the first knot vertically, then go horizontal, vertical. That's the classic teaching. The next suture is the most important one because that's going to divide the graft into two equal halves. So you make sure a vertical line is dividing the graft into two halves, as you can see here, approximately at least, and then take a 90% depth bite on either side again. If you mess this step up, it's going to prove a problem moving forward because you'll have an overhanging edge on one side and you might need tighter sutures to oppose the graft on another side. So don't hesitate to redo this suture if you haven't got it right the first time. Again, this suture is also going to be a little bit tighter, and you must always revise your cardinal sutures at the end of surgery to make sure that your sutures are all adequately or equally tight. Proceed to take the third and fourth cardinal sutures similarly. And towards the end, you'll see a sort of a diamond or a rhombus forming. So a symmetrical rhombus or a symmetrical diamond rather, a rhombus is symmetrical, would indicate that your sutures are appropriately placed and have equal tightness. If you feel that the diamond is a little skewed, you can always redo your sutures. But after this point, at least, it's not an open sky anymore. You can use the side port, preferably to inject viscoelastic, and then proceed to place the rest of the sutures by bisecting these four sutures. So the proper way of holding the needle would be to hold it at the superior 1/3 and inferior 2/3 junction, with the needle making a 90-degree angle with the needle holder. And then when you take a bite, the needle has to be at a 90-degree angle, 90% depth, a lot of 90s over here. And as much as possible, especially in optical keratoplasty, it would be preferable to take the bite within the avascular rim of the cornea rather than encroaching into the sclera. However, sometimes with therapeutic keratoplasty, we can't really help it. So proceed to place the rest of the sutures. Thoroughly wash the anterior chamber at the end of the surgery because any retained viscoelastic is going to increase the intraocular pressure. After forming the anterior chamber and looking for leaks, it's time now to bury the sutures. Again, there are two schools of thoughts. One that say you should bury it on the donor site to decrease vascularization and decrease the chances of graft rejection, which really isn't an issue with therapeutic keratoplasty. And it is also uh, advocated that if to bury it on the host side, because if you bury it on the donor side, during suture removal, it's going to exert some traction on the corneal tissue and cause some there might be a chance for the graft to dehisce. So that's the end of my presentation. So before all of this happens, you need to make sure that there is adequate block administered to the patient, preferably a facial as well as a peribulbar block. Make sure the patient has had IV mannitol or oral glycerol if systemic conditions permit it, because you're only going to be as comfortable as the patient on your table. Otherwise, the surgery is going to be hell. Yeah. So, and beyond that, there are two things that's most important that you need to keep in mind is you completely remove the infective foci, because otherwise that would defeat the purpose of doing a therapeutic keratoplasty, and make sure your anterior chamber is completely formed. The angles are opened by the end of your surgery. Otherwise, of course, there's a very high risk of developing secondary glaucoma, and the prognosis of this eye is not going to be that great. And regarding removal of the lens, this patient had a clear lens, and because there was a nice corneal rim around, we could ensure that the anterior chamber is well formed. But when the graft is on the larger side, on the other side of say 10 millimeter, it might not always be possible. However, try to preserve the lens wherever possible, and also making sure that the anterior chamber is well formed. In case there is if it's a pseudophakic patient, you might feel that the IOL is bulging up and trying to come out when you start suturing. Keep suturing. Once you're, say, about 8 sutures in, it is going to settle and the tamponade is going to push the IOL downwards. Yeah, that's the end of my presentation. Thank you.